Okay, it's a pleasure to welcome A Masud, who's going to talk us about developing a model-based pipeline for combination therapy.
Hello, guys. Today we are going to talk about the second-line therapy for KRAS-mutated lung cancer. And the key points that we're going to discuss about in this talk is, can we improve the second-line therapy for KRAS-mutated non-small cell lung cancer? And can we use a drug that is not specific to KRAS to improve this treatment? That is a secondary impact of a targeted drug. And we will try to come up with some guideline for treatment cycling. So for non-small cell lung cancer with KRAS mutation, the first line therapy are like chemotherapy and immunotherapy. And when it relapses, then it comes KRAS inhibitor. And when this one relapses, then it goes back to chemotherapy. So one of the recent approval by FDA is sotorasib as KRAS inhibitor by this trial, CodeBreak 100. But what happens is sotorasib has been so far criticized by many people due to like for its efficacy, because if we look at these two curves, that sotorasib has very marginal benefit over one of the competing drug, docetaxel. And as it relapses, the relapse mechanism includes amplifying the signaling in the neighboring pathways. For example, when sotorasib attacks the KRAS pathway, then the cancer cells try to activate the neighboring pathways, for example, EGFR, MEK, or CDK, to compensate the loss caused by sotorasib. So in this work, the target was, can we deal with this situation by combining any of these three drugs that attacks the neighboring pathways with sotorasib, and does that help us? So here our target is mainly to improve this second line therapy. So can we combine the sotorasib with any other drug that can help us reduce the tumor burden? To be too optimistic, we may have extinction. Otherwise, at least we can try to delay the progression. So with that intention, we had mouse experiments where mouse with tumor cells, and then after 27 days when the tumor grown, then we treated mouse with monotherapies with sotorasib, afatinib, trametinib, and palbociclib, as well as with combo therapies where we combine with the other three drugs. And on the right side, we see a pattern of how the data looks like. And looking at this pattern, we choose the most simplest TGI model. And the TGI model looks like this. The nice thing is we can solve this analytically. So V is the tumor burden, and gamma is the...
Sorry, just let me do this. Where's that part? Why is it not sharing? Does that work?
I can see it.
No.
Andy,
With
the extended display and put the screen around.
Say that again. I know what to do. We just do. Yeah, that's what I'm going to do.
Direct mirroring. Exit. Click this button.
Stop.
Now, choose button. And say
Entire screen.
no. Yes. Now it should work. Hold on before go ahead. Is to Zoom? No, you have to share Zoom first before you do your presentation.
We just need to swap. Is that it? Thank God for that.
Thank you. So let's get back to the TGI model. Yes. So here, V is the tumor burden and gamma is the drug response. So if we look at, where's the pointer? Yeah, here. So if we see that initially when the drug response is high, then the tumor decrease. And when the drug response levels with the growth rate, lambda, then the tumor volume is at the nadir, and then the tumor starts to rebound when the drug response goes below the growth rate. And so here's some of the interesting metric that we will use is the nadir V mean and the time to reach the nadir T mean and the time to progression TP, which we define here as the time when tumor rebounds to its initial volume. And as we are using a very simple model, we can have explicit expression for V mean, T mean, and also for time to progression. Here we have shown the sensitivity of the nadir with respect to epsilon and gamma zero, which is the like initial drug response, and this is the resistance rate. As the TGI model, it will never reach to zero. So how do we define tumor extinction in terms of TGI model? So in the view of TGI model, if we want to explain tumor extinction, then we will expect for the tumor, the nadir to be too low enough for like a stochastic extinction. So here we show a red line here, which will be interesting. We will get back to this red line later on. On the right side of this red line, we can expect that this type of combination of epsilon and gamma zero will produce low enough nadir for probable extinction. So this is the flow, like workflow for our like model with data. The first what we do is we use the control data to estimate the growth rate, setting the resistance rate and the drug response to zero. That gives us the growth rate, and we this is the average growth rate we feed to every tumor. Every mouse has two tumors on the left and the right, so we feed the data to every tumor. So this is the average growth rate that we use as a common growth rate for all the rest of the tumors. And that helped us to reduce our problem of fitting to a structurally identifiable problem. And so this is the fitting for the control mouse data, and we see that at this fitted lambda, all the cost functions are minimized. So this is the proof that if we know lambda and if we estimate the other two parameters, that it is structurally identifiable. If anyone is interested about the proof, we can discuss about identifiable except one tumor, this one. Okay, so we have the fitting for all the tumors. Now let's use the parameter values about which we are more interested about. So very interestingly, if we see that the initial drug response of sotorasib is not significantly different from the combo therapies. But what the difference is, the combo therapies reduce the rate of resistance. So from here, one of the main takeaway is combo therapy slows down the resistance accumulation, and that makes the big impact. And then what are the other benefits? Here we see that time to progression is delayed in the combo therapies with respect to sotorasib. And then, as you're combining the drugs, it is important to investigate that whether the drugs are synergistic or not. So that's what we do is we use the idea of Bliss criteria. So we use the monotherapy estimates, for example, sotorasib and afatinib, we put in the Bliss model that gives us a predicted estimate of the combined potency of the combination therapy. That is, and then also then you compare it with the estimated drug response with the combo therapies. So if this estimated or observed drug response of the combo therapies is higher than the predicted, then we can say, according to Bliss criteria, they are synergistic. So this is for one point, but here we have drug response over like long as we did the experiments. So we did it over time, and to compare, we take the area under the curve and normalize with respect to the sotorasib. And that shows that in the case of sotorasib and afatinib and sotorasib trametinib combination, we get about 17% more than the predicted. And in the case of sotorasib palbociclib combination, we get about 26% more than the predicted. So it shows that the combinations are synergistic. Now we plot the estimated values of epsilon and gamma on this like epsilon gamma plane, and we like get back to that red line. We portray that red line here. So here we have that line for 1% threshold or 0.1% threshold, and we see that these are the all sotorasib blue dots, and these circles are for combo therapy estimates. And we see that some of the combo therapies exceed 1% threshold, that it can reduce the tumor nadir to below 1% of the initial volume. And another important thing is in the expression of nadir, we have seen that it depends on the initial tumor volume. So the point is, if we use one combination for reducing the tumor, then with this initial smaller volume, we start with another combination. We may get, with the combined effort of this sequence, we can end up with a much lower nadir that could be like enough for extinction. So with that hope in mind, we extend our model for cycling treatment, where we use one drug first, then use a second drug, and when we come back to the first drug, then it either resensitize for the other drug, or that depends on the parameter rho. If rho is positive, then it resensitizes against this second drug. If rho is negative, then it will also make the tumor resistant against the second drug. And then when we go back to the second drug, then it may again resensitize, or like this rho1, rho2, if it is negative, it's collateral resistance. If it is positive, it will be collateral sensitivity. So first we go back to a bit simpler case where we don't have any collateral resistance or sensitivity. So in such case, we have mathematically proved that the cycle length, the treatment outcome is invariant of the cycle length and sequence, and we can have an optimal switch like one drug resensitize the other drug, but in this case we see that one drug also makes the tumor cells gain resistance with respect to the other drug. But where here we see that when the drug is off, there is no change in sensitivity of the other drug. Now try to like explore this more, because we don't know the parameter values of rho1 and rho2. That's why we try to check the simulation results for different values of rho1 and rho2. It looks very busy figure, but we try to focus on this one case. So here we tried simulating the treatment for different scheduling of the lower row shows time on drug 2, and like vertical column shows the time on drug 1. So the first hit plot shows the nadir, and the second one shows the time to progression. And here we see that This combination gives us the delayed progression and lowest nadir, and this combination gives us the quicker progression, highest nadir. So let's look at these two cases in more detail. So this is the case when the solid line is the case when we have the lowest nadir and delayed progression. Here we see that the weaker drug is used for 3 weeks and the strong drug is used for 1 week. Normally we should expect that a stronger drug is used more than the weaker drug. But here we see that the weaker drug is used more than the stronger drug. And the reason is the weaker drug is sensitizing the tumor to the stronger drug. So that's why if a drug that resensitizes the tumor to a stronger drug, then we may need to use the resensitizing drug more than the strong drug. So now we get back to here we see that this was the case when we have most delayed progression. We're using, you see, this is here gamma 2 is 0.2 and here is 0.25. So drug 1 is the more potent drug, but if we want to get the best outcome, we will use the drug 1 less than drug 2, because drug 2 will resensitize tumor and keep it vulnerable to drug 1 for a longer time. And let's get back to that busy figure. So here we see that this part is for positive rho 1, rho 2, that is collateral sensitivity, and this part for collateral resistance. So, and here we are interested about this red zones more, and here we are interested about this blue, because this blue shows the lowest nadir. So if we go diagonally opposite, we see there is no blue here, rather the blues are here. So it shows that if we have collaterally sensitive drugs, we use smaller cycling. But if we have collaterally resistant drug, it's better to use longer cycles. So the conclusion that we come up with is, yes, we can improve the second line therapy by combining sotorasib with some other targeted drugs that does not target exactly KRAS, but targets the neighboring pathways. And if there is no cross resistance, if there is cross resistance, we better use longer cycles. If there is no cross resistance, the cycle length and the order doesn't matter much. If there is cross sensitivity, it's better to cycle the drugs. And if we have a sensitizing drug, maybe we will need to use that more. And some new way of thinking, we might say that the people who are doing drug discovery, they are more interested about the drug potency. But here we see that drug sensitizing ability of a drug could be a new parameter of interest that we might be looking for even in the existing drugs. And sometimes the drug that is not targeted to a specific mutation might be useful, as we have seen here that afatinib or trametinib or palbociclib is helping KRAS mutated cancer. So that's it for my presentation. So I acknowledge the contribution of the experimental team here from Andre's lab, Daria, and also all the help from Mark and Sandy. And it was funded by COE pilot grant. And interestingly, this project started from 2 years back. I am a workshop that is going to happen again this year after exactly 3 days from now.
Okay, time for a quick question. Is there any?
Presenter view.
Yes. Let's see when we get this up. How does that look?
Is that better on?
There's a question there.
Is that better on Zoom?
Good.
Thanks for an interesting talk.
Thank you.
When you say that the sensitizing ability could be a new focus for drug discovery efforts, can you also suggest, or does your modeling suggest any way of measuring that? So when you have a new drug, what should we go after
Yeah, of
to
course,
achieve
like
the sensitizing ability?
yeah,
Or-
if we have a cycling treatment with the drugs or drug combinations, we can estimate the parameter values row 1 and row 2 that we have seen in our model. Because we have that type of data, but that is too limited to claim anything with the data that we have. Maybe we can plan that type of experiment later. But of course, yeah, if we have cycling treatment data, then we can use that to estimate this row 1 and row 2. That will tell us that how much resensitizing this drug could be. Yeah. Yeah, cycling data. Yeah. We need. Yeah, but I believe if we do the experiment systematically, for example, with this model, now we know all the parameters. Now if we extend to cycling model, we don't know only 2 parameters. So with the data, we'll be able to estimate those parameters.
Okay, thanks again, Masud.
Yeah, thank you.